Greetings. I will be talking about clinical experiences, challenges, and the way forward on this symposium, Salient Aspects of Substance Use Disorder among Elderly in India. I am Dr. Siddharth Sarkar. I am an additional professor at the National Drug Dependence Treatment Center, Ghaziabad. My field of interest are addiction psychiatry and medical education. I am currently the deputy editor of the Indian Journal of Social Psychiatry. I do not have any conflict of interest to declare, and the presentation is largely experiential with some literature strewn. Now, the first question is, do elderly with substance use disorder actually exist, or do they mature out and the population is not existent of substance users among the elderly population? And the answer is yes, they do. And herein, we present the case of a 98-year-old gentleman who came to us who had a history of opioid dependence, who had been taking 6 decades of natural opioids, and he came for treatment because he was finding it very difficult to procure his opioids in the form of opium, Doda, and Bukti, and he was maintained well on treatment with tramadol. Interestingly, he came alone. He was able to move and use transportation and come alone by himself for his treatment. We share another experience of treatment outcomes of aged substance use users admitted to our center. We tried to look at the population of patients who are getting admitted. In them, uh, we found that 72 out of the 953 admissions were of those who were more than 50 years of age, and a smaller proportion of them were those who were aged 60 and above. Herein, the most common diagnosis was alcohol dependence, and then followed by opioid dependence. The mean duration of stay was around 13 days, and of them, treatment could be completed of 57 patients, that is around 80%, and some of the patient had to be discharged due to medical reasons as well. Treatment completion was least among patients with opioid dependence, and it was more commonly successful for those with alcohol dependence. So that means that among the patients who were admitted, about 7.6% are aged more than 50. And of these, about a quarter are those who are aged more than 60 years. Herein, alcohol dependence seems to be more common as the presenting complaint for admission rather than opioid dependence. Now, herein, let me share another interesting clinical case of a 65-year-old male who was brought with a history of smoking bidis for last more than 40 years. He has also a history of bipolar affective disorders, and he smokes more during the episodes of mania. During remission, he does not quit smoking, he continues to smoke. He was counseled. His family members brought him because he was smoking still when he was in remission. He was counseled, and he briefly was tried on bupropion 150 milligram and then 300 milligram as well. He stopped smoking for a week, but then he resumed. So the challenge here lies of how to manage patients and to keep them abstinent from smoking for longer periods of time. Another interesting case was of a 76-year-old gentleman who was brought by family members on a wheelchair. He used to demand alcohol to be brought to him daily in the evenings. And if the sons did not bring alcohol, then he would create a ruckus at home. He would be angry. He would be shouting. So the usual consumption was 1 quarter only, and there was no daytime drinking. He was a known diabetic and hypertensive, and he was being urged by the other doctors to quit alcohol, but he wasn't ready to. He was on medications for diabetes and hypertension, and these were under fair control. He was asked to quit alcohol, and the family members found an interesting strategy of mixing water in his alcohol bottle, because they used to get the alcohol for the patient and they would dilute. He would sometimes be grumpy that okay, it is not giving him a good kick, but nonetheless, they would say that it is fine and something is problem with the patient, and they would try to convince him and give still nonetheless alcohol, but a diluted. We were wondering in this case about how to manage. We cannot admit him. He was bound on a wheelchair. He wasn't motivated. Getting sessions on a regular basis was difficult. So these were some of the challenges that we were encountering in such elderly patients. Now, sharing another clinical experience, how are we managing the opioid dependence in our setting in the elderly? OST in the form of buprenorphine is used in our center when the patient is able to come for daily dispensing for a couple of months and then for take-home weekly dispensing. Tramadol is also quite frequently used here in cases when the patient is unable to come for daily dispensing. It works fine in many cases, especially natural opioid users. Detoxification or drug-free and possibly naltrexone is an option, but it's a very challenging option. People are not able to detoxify, especially when they are old and aged. Now we share the experience of using tramadol as a maintenance treatment for opioid dependence, in which we had enrolled around 102 patients. The mean age was 41.3, and we found here that older patients and those with longer duration of opioid use were more likely to achieve abstinence, largely because they were dependent on natural opioids like afim, dora, and piki. But we found that many of the older individuals were doing okay with this medication. Now, what drives individuals with substance use disorders, the elderly, to treatment? One of them is family pressure. The family wants them to quit, and with time, they find financial crunches. They become dependent financially. They have to ask for family members for the consumption of substances, and which becomes embarrassing at times. And that is why people think about quitting substances. There is stigma and social pressure as well, which drives them to treatment. Then often medical professionals whom these elderly individuals seek for treatment, for example, for hypertension, diabetes, etc., they counsel for cessation or abstinence. And as lifestyle changes occur over a period of time, that also drives elderly individuals into treatment. Now, what are the kind of challenges that we face? So these challenges can be many, and of them, logistics is one of the important ones. How to transport these individuals, whether someone will come to accompany them or not, or whether they'll be able to come alone. Then in logistics is, well, will they get money to make arrangements for coming uh, or for paying the fee of the doctors when applicable? And the next related thing is whether they will have any insurance cover that will cater to the expenses about these treatments. So logistics is an important challenge in treatment of these individuals. Then there are medical issues that becomes another challenge. Often elderly individuals have multimorbidity, that is, they suffer from multiple conditions simultaneously, and those conditions may impact the substance use disorder or the medications, and interactions of these medications is another point of contention or problematic issue that may happen. For example, some of the medications for treatment of hypertension, they may have an interaction with the treatment for substance use disorder as applicable. Then, if there are certain impending surgeries or procedures that are likely to happen, that may be another medical issue that may complicate the treatment. And side effects of treatment may be another issue in the elderly population. For example, when we want to give benzodiazepines for cessation of alcohol use, we need to titrate the dose carefully. Then there are certain challenges from the healthcare system also that may make the treatment difficult. For example, waiting times. So if we are asking the elderly to wait for a long period of time, they may find it difficult. Then there may be a kind of a thought about the perspective of ageism from healthcare. That means that if we start considering that they are bound into their habits and they're not likely to listen to us, that is also another issue that may lead to a barrier or a challenge in treatment. Then there may be cultural barriers. For example, the most of the healthcare providers would be younger in age than the elderly, and hence they would be little hesitant or cautious in recommending very strictly or very directly to the elderly population. Then there may be a judgmental approach as well to the elderly, that here is an elderly gentleman or a gentlewoman who's taking substances. And if we start having a judgmental attitude, it may interfere with clinical care. Then there can be personal or social issues with the elderly themselves that may hamper the treatment or may pose challenges to the treatment. For example, the family attitude to the treatment. If the family does not think treatment is likely to be of any benefit, they may not come. Then own attitude to treatment as well. If the elderly think that they won't be benefited with treatment, they may not like to come. There may be stigma and shame in seeking treatment that others may come to know that I'm going to so and so place. Then a feeling of being in control might also be there. The person may think that, okay, I drink so only this much, and it's a habit that is okay habit, and I can quit it any day. So that may be a barrier to treatment or treatment seeking. And then there might be fatalistic attitude towards the future that, I've passed a lot of my life and only some is left. So let me enjoy in the manner that. So these may be personal or social challenges to treatment. Each individual circumstance is different, and then there is a interaction of the substance using elderly, the healthcare system, the family social environment, and the economic reality. So all these have an influence on whether an individual is able to seek treatment and to what extent and from where the individual is able to seek treatment. So being cognizant of these may be good, but we may not be able to change all of these factors. So the way forward, if I can suggest in three different headings, would be of the healthcare, the social family dynamics and constraints, and the system or the economic issues that can be handled. From healthcare perspective, we should be sensitizing the healthcare professionals. We should train them. We should train them about how to help the elderly better, what kind of evidence exists, what are the best practices, and what would be the appropriate attitudinal methods of helping. More experience is required, and more experience needs to be shared about helping people who are older and they are coming with substance use disorders. From a social and family perspective, we should educate the family as well as the society about substance use disorder as an illness. And we should also educate about treatment being available and effective treatment being available. The treatment works for many. From a system and economic point of view, we should try to make efforts to support travels by the form of either some kind of subsidy, and we should try to address the treatment cost that this elderly face. Otherwise, they may be compelled to stop treatment due to financial issues as well. We should rationalize our prescribing, especially in the elderly, especially in terms of benzodiazepines and opioids. We should use the doses minimally and for the minimum duration. We should use them nonetheless, but we should use them rationally. Rational use does not mean no use. The medication should be used as and when indicated, as and when required. Thankfully, we do not have a prescription opioid epidemic in India yet, and I hope it does not occur in the future due to minimal use of opioids in India. But nonetheless, the rational prescription should continue. So to conclude, elderly substance use and substance use disorder is a reality. Efforts are required to address the issue. Many challenges are there in the clinical care of the elderly, but nonetheless, these challenges can be addressed. Treatment approaches can be effective in the elderly, and with treatment, many of them see benefits in health as well as psychosocial functioning. With this, I would like to thank you for your patient listening.